Well, dear ladies and gentlemen, even the attention is not very big. We have to start. Those they are sleeping, they will miss the best part of their fall. And so I would like to invite the first speaker, our co-chairman, to tell you something about the book.
Good morning, dear colleagues. Some time ago, is the first slide, please. Some time ago, I visited Italy, visited Florence, and suddenly in one small courtyard, I have seen very strange construction. You see it. It was a very amazing sculpture named All That Remains. And I agree with the creator of this sculpture. It's really all that remains in our life. And I sure, and I think you agree with me, that the operation which Christian Barnard performed 50 years ago, the first human-to-human heart transplantation, is the events in same category. All that remain. Next slide, because it's not work. What is it? Try to next slide. Okay. At that time, 1 year ago, many of us, we visited the 26th Congress of VSCTS in Cape Town. And in Cape Town, unusually situation, I visited memorial operation of Christian Barnard. It's a really memory operation. When I put this picture in Facebook, many people asked me, what is it? Why you visited operating room in civil clothes? But this is a memorial operating room. You see Christian Barnard and Marius Barnard, her brother, and this is a really feature, like in Museum of Madame Tussauds. They perform this memorial operating room, and I have seen in this museum the book Heartbeat with the author of Michael Lee. And we decided with the president of this Congress, Yuri P., we decided to reprint this book and prepare this book like a present for all participants or our Congress today. You have take this book in the enter of this Zal. Yeah? And next slide. Next slide, yes. It's a Christian Barnard at that time, 44-year-old, when he performed this first heart transplantation. Norman Chamway, real father of this surgery. And this, I think, is a unique telegram, which Norman Chamway to send to Christian Barnard really after this first heart transplantation in the world. And this is the book which we reprint. And now I would like to say thank you to Michael Lee, author of this book, who understand that it's very important to remember about this very famous story in human beings. And thanks to director of publishing house in Moscow, Rustem Valeev, who understand this idea, and now we have this book, and I wish you to reading this book. Thank you.
Thank you very much. It's really interesting, and well, we will try to understand because it's in Russia. So we will move to the first scientific paper from Mayo Clinic, combined heart and liver transplantation.
Thank you, and I want to thank Yuri for the opportunity to be here and have a chance to participate in this great Congress. Rokmirt. I don't have any relationships to disclose. The Mayo Clinic is in the north part of the Midwest of our country, which is pretty sparsely populated, and as a result, we don't have access to a huge number of donors. We also have several other transplant centers in our area. This is our heart transplants per year since our program started in 1988, and we do about 30 heart transplants a year, which is just donor limited. We have a very large waiting list, actually, almost 100 patients. But we have also had quite a bit of experience with combined organ transplants. In the yellow are the combined organs each year that we've done because of a good relationship with our abdominal transplant colleagues. So in this time, we've done 48 combined heart kidneys and 40 combined heart liver transplants. It's actually it's a small number of heart liver transplants, but it's actually, relatively speaking, a very large number for any one center. The combined heart liver transplants in the US are shown here, and you can see the numbers going up in the recent years, probably because of willingness to take on these patients and a little more of an understanding of the issues with transplant. If we look at the total liver heart transplants in our country per year, this is the segment that's highlighted here that we've done at our single center. So while the number of 40 isn't large, it's still a relatively good share of the total transplants done in the US. We do them primarily for familial amyloid, which is pretty straightforward, and for congenital heart disease, which is not very straightforward. Most of the congenital heart patients are right heart failure, like failing Fontan physiology, and congestive hepatopathy, congestive cirrhosis. This is the characteristics of our patients, age 57. More than half were in the hospital waiting for transplant. There was one on an LVAD and one on an RVAD. And the donors obviously have to be pretty vigorous to tolerate an immediate liver transplant, so they are selected to be vigorous. The donor age 32 years. Our cardiac ischemic time is the same as for isolated heart transplant, and the liver ischemic time actually is shorter than isolated liver because they go right ahead when we're done with the heart, and that's the bypass time. Among the patients that had transplant for familial amyloid, about half of those livers were able to be used. The livers being removed from the transplant recipient were able to be used in another recipient, so it didn't take actually a liver out of the total organ availability pool in these domino cases. Among the 40 patients, we had one operative mortality, which I'll tell you about. There were some lessons to learn there. This is the survival for our patients. This is the survival for combined or simultaneous heart and liver, for isolated heart, and for isolated liver transplantation. So you can see that the combined cases have very similar survival, and I I think one needs to aim for that to justify using multiple organs like this. If the survival was not as good, I'm not sure we could be as justified. One of the big differences for the combined heart and liver is a longer hospital stay compared to isolated heart transplant. And this was mainly related to rehabilitation of these amyloid patients. They all have a certain amount of neuropathy and decreased GI function from their amyloid disease. And one needs to keep that in mind when one is selecting appropriate patients for this procedure. But they do take a while to get them mobilized and independent before they can be dismissed. Our immunosuppression protocol is the same as isolated heart transplant. We prefer an induction protocol to spare tacrolimus and renal function early after transplant. And we actually have a protocol to convert all of our patients to sirolimus late after transplant. That's another discussion. So this is something that we've noticed in the combined heart-liver. There was considerably less rejection. This is freedom from rejection for isolated heart transplant compared to simultaneous heart-liver. And you see the isolated have lots more rejection. And this was true whether cell-mediated, this is just the cell-mediated rejection, and this is antibody-mediated rejection. And in fact, we see almost no antibody-mediated rejection in the heart-liver patients, which is quite interesting. Here is donor-specific antibodies that were present at the time of transplant, for blue for the heart and liver, and for red for isolated heart transplant. And in the isolated heart transplant, later after transplant, many of them have donor-specific antibodies, which they develop over time. But in the combined heart-liver, they don't develop more antibodies. If anything, it goes down a little bit. So there is a protection here. And it's reflected in the allograft rejection. We see the combined heart-liver allograft rejection is down at the bottom, down here. They really don't get allograft vasculopathy over time after combined heart-liver, which is remarkable. So the liver has an immunoprotective benefit for the heart, provided it's from the same donor. That's important. And we make immunosuppression therapy decisions with that in mind. In the surgical strategy, having recognized this immunoprotective benefit in 34 patients in whom the liver was placed, in whom the heart was placed first at the time of the transplant, in 6 patients were very highly sensitized and were really not candidates for transplant because of sensitization, but they needed heart and liver transplant. And in these 6, when we did the transplant, the liver surgeons put the liver in while the heart waited in the bucket. And then when they were done with the liver transplant, we did the heart transplant, with the idea being that the liver would eliminate the antibodies. And we reported this at the most recent heart-lung transplant meeting in San Diego in April. So among the 6 patients, 5 were female. The ages are there. All of them had had previous sternotomies, which caused the sensitization. The average calculated PRA was 76%. And at the time of transplant, they all had donor-specific antibodies. These were their previous sternotomies, a couple of Fontan patients, AV canal, one patient with an RVAD, one patient with a BIVAD. You see, these are very complicated operations, and having them do the liver transplant first means that there's a great deal of sort of choreography to get this done, where the cardiac ischemic time was acceptable at a mean of 223 minutes. We had no operative mortality. There was 1 death at 6 months from recurrent hepatocellular carcinoma, and of the remaining 5 patients, we have follow-up out to 36 months with normal heart function in spite of high donor-specific antibodies. All of them had a prospective cross-match that was positive. This is the T-cell flow cross-match. This is the negative value. A couple of them are pretty low, but some of them are very high. And among the highest prospective cross-match, these actually had a positive cytotoxic cross-match, which would be a contraindication normally to going ahead. When we repeated the cross-match the day afterwards with the same donor and recipient, the cross-matches were all negative. The cytotoxic cross-match was negative and the T-cell flow was negative. And this was also true of the B-cell flow cross-match, initially positive in all the patients and became negative. And the donor-specific antibodies were present pre-op, but post-op they fluctuated some, which I won't show all the details here, but they have basically come down over time and stayed down in all of these patients. So the liver removed the antibodies. In the other 34 patients in whom we did the heart first, there were a couple of lessons I just wanted to mention. They're illustrated by these cases. This case should have been a straightforward transplant for familial amyloid. But I want to make the point that during the combined heart and liver transplant, the patient received 20 liters of fluid, had 10 liters out, but was positive then over 9 liters, which is tough on a brand new heart doing the transplant. So one of the lessons is to, we talk to the liver team the liver anesthesia team that takes over while they're doing the liver transplant, and we ask them basically to give no fluid, where they normally would run in some liters of fluid during a liver transplant. And we treat RV failure very aggressively in these patients with nitric oxide or alprostadil, and we used an RVAD in one patient to bridge the right ventricle. But the point was, the message was to keep the RA pressure very low. And then a word of caution about a second case. This was the mortality that I had mentioned earlier. And this should have been a straightforward transplant. It was familial amyloid, so no previous heart surgery. Combined heart and liver. The heart went in first. The heart, the heart was working really beautifully well. Everything was going great. And then an hour after the liver was reperfused, the patient developed this terrible acidosis. The hemoglobin went to 4. There was a terrible coagulopathy. On echo, there was thrombus in the left atrium. The heart function was poor. We had to put the patient on ECMO. And what had happened, well, this was the TEG after the heart transplant and before the liver, and you can just see the difference in how it looked after the liver was reperfused. So what had happened here was that the patient had systemic intravascular thrombosis, and it occurred after the veno-veno bypass for the liver transplant. And probably what this was related to is that after we gave protamine, there was normal coagulation after the heart transplant, and this liver has normal synthetic function. It's an amyloid. But with the heart protocol, we continued Amicar, and with the liver protocol, they didn't give any anticoagulation for their veno-venous bypass, and that probably was the error. So now we do maintain anticoagulation for all of these patients, and we've changed the liver transplant protocol for that, and we've changed our heart protocol to avoid the antifibrinolytics. So we've had good results both with combined heart kidney, which I didn't present today, and combined heart liver. We're careful with recipient and donor selection because we think we should be expected to have good outcomes. The liver clearly provides an immunologic advantage for the heart, and perioperative management requires attention to fluid administration, RA pressure, and anticoagulation. Thank you very much for your attention.
Thank you very much for an interesting paper which is open for discussion. Any questions from the floor?
You have a question?
I have a question, Richard. Congratulate you with a very nice, very important job. But 2 questions. The first is, did you see transthyretin amyloid for all patients?
Yeah, these were these were familial inherited amyloid cases. Yes, we do a heart transplant for amyloid, other amyloid disease, but for familial amyloid, we generally do combined heart liver. And the liver can be dominoed.
Yeah, thank you. And second question is, how often did you use heart and liver from one donor?
Yeah, they're all from one.
And is it different between the long-term result from one donor or from 2 donors?
So that's right. So In one of these cases, we were not able to go ahead with the liver transplant after the heart because the patient was unstable, but it had a normal hepatic synthetic function, so we relisted for liver and did the liver 3 months later. But all of the others were from the same donor. We think that's clearly where the immunologic advantage comes from. There's no advantage if they're not from the same donor.
Okay, and one question more. Did you see the reaction graft versus host, or no?
No, that's a good question. We haven't seen that any more than would be common in isolated liver transplant. And they're not seeing that too often. So it hasn't really been an issue for us.
Thank you, congratulations.
Yeah, we did one, I'll say we did one combined heart, lung, liver, and we did have graft versus host in that patient. Yeah.
Thanks.
Yes.
Do you use whole for the liver, or you sometimes split? For the liver, you use whole livers, or sometimes you split to 2 patients?
For these cases, we use all of it because there's the time issues and the stability of the patients. They do split livers, but we haven't done that for any of these.
Okay.
Yeah, thank you.
So really no question from the floor? If not, thank you very much. And we move to the third paper, heart transplant in the Gulf region from Abu Dhabi.
Morning. I'd like to thank the organizing committee for including me in the program for this wonderful meeting in this wonderful city. I would like to thank you for being here so early.
So what's the problem?
I don't know, it looks like they didn't transfer the presentation that I uploaded over there. So they're just using a backup copy. So let me just start by saying that the only disclosure I have for this session is that I'm not a surgeon. I am a heart failure and transplant cardiologist, and I work as the director of the heart failure and transplant program at the Cleveland Clinic in Abu Dhabi. My job will be to just give you some perspectives on heart transplant in general in the Gulf region. So I'll talk to you a little bit about the region and the epidemiology, the current status of heart transplant across the whole region, and some of the limitations and lessons we learned as we're trying to develop our transplant programs over there. So this is a map of the Middle East in general. And this is the map highlighting the Gulf Council countries, which would be 6 countries represented by the purple color here. If we take this region, it's approximately 1 million square miles. This is about 25% of the total US area. So it would be smaller than the size of Kazakhstan as a country. The population is estimated around 50 million. Heart failure population, if you take US statistics as a comparator, there would be approximately 1 million patients. Advanced heart failure population, therefore, would be around 50,000 patients. And if we assume that we should be doing the same numbers of heart transplant like the US, we should be doing 500 transplants every year from our region. This is an example of the cardiovascular risk factors that we see in the Middle Eastern countries, and highlighted in light green here are the Gulf countries. I just wanted to emphasize the prevalence of diabetes in the Gulf countries. 4 out of the 6 countries would be in the top 7 worldwide in type 1 diabetes, which means that people live with diabetes for a longer period of time before we find heart failure. This is a unique thing that I found as I started practicing in the region moving back from the US. There's also a high prevalence of obesity, with almost 1/3 of the population being in the obese range. This is an interesting report discussing transplants of Middle Eastern patients in the US from the ISHLT database. And what's important to highlight here is that outcomes actually were similar to US patients when it comes to survival between Middle Eastern patients, Gulf patients, and other patients from the US in general. If we take down the characteristics of patients transplanted in the US from the Gulf region, we found that they're pretty much split. Almost 40% are pediatric and 60% are adult. What's interesting is that they're mostly 1A, 1B for their status at the time of transplant, which means that they were generally sicker patients compared to the transplant population altogether. Now, the numbers are not very high. The total number of patients in these 14 years that were included in this analysis were 72 patients from the GCC countries and another 25 from the Middle Eastern countries. So we're talking about approximately 100 patients from the Middle East transplanted in the US during this time period. It's also interesting to highlight that the wait list was shorter for these patients compared to patients transplanted in the US in general. Again, probably because they were on the sicker patient profile. So right now, the only sizable heart transplant center we have is at King Faisal Specialty Hospital in Riyadh. They've done approximately 200 transplants in 25 years. More than 95% of these were Saudi citizens. The rate of transplant, therefore, will be 0.5 per million persons per year, which is 20 times less than what we know in the US. If we look at the age groups, they're nicely distributed among all age groups for their 200 patients over the last 20 years. Average waiting times have changed depending on the era. So in 2008, waiting time used to be approximately 2 months. In 2012, it's almost 9 months. The current status of heart transplant in the Kingdom of Saudi Arabia was represented in this paper to just highlight the improvement in survival between older transplants and newer transplants. As you can see in the table below, survival across all time periods, across all time points, have improved between the era of 1989 to 2000 and then 2001 to 2012, basically, which would be a translation of the improvement in immunosuppression management as well as support from other services at the transplant center. So what are the potential limitations for establishing heart transplant programs in the region? Number one, it starts with establishing advanced heart failure and transplant programs in general. The availability of donors and the public acceptance of organ donation, and of course laws and regulations on brain death and cadaveric organ transplants. We all know that heart transplant is a multidisciplinary effort that involves a lot of people, including cardiologists, surgeons, as well as a host of other administrative and nursing supporting personnel. The concept of establishing advanced heart failure programs is not yet widely accepted in the region. One, either that the resources are not available always to establish such programs. Two, the acceptance of dedicating all these resources to one program to generate ultimately advanced therapies is not always accepted by lawmakers and also health policy legislators. So we know that the goals from establishing advanced heart failure and transplant programs is to educate patients and families about heart failure, reduce readmissions, optimize medical and device therapies, provide timely and thoroughly follow patients with end-stage therapies such as ventricular assist devices and heart transplant, increase the length of life whenever possible, and of course improve the quality of life. Understanding these concepts as important drivers behind establishing advanced programs, again, is something that we have to struggle with to convince certain health care policymakers to dedicate the needed resources to establish these advanced programs. But it's important to understand that because only 5 to 10% of all heart failure patients are advanced end stage D patients, which makes most of the effort dedicated towards improving the progression of patients to advanced stages. And that's exactly the concept that we're trying to establish across the Gulf region, so we end up with less advanced patients and less need for advanced therapies. Again, it's not only the cardiac and cardiosurgical side of things, but we also need a host of support from other services and specialties which are not always available in certain countries and within the same country in the peripheries outside major cities. Availability of donors and the concept of organ donation. This is a big issue when it comes to establishing heart transplant programs simply because it requires cadaveric organ transplant. I can tell you that we don't lack donors. What I wanted to show you in this picture, not exactly that somebody's riding a motorcycle, but the person behind him standing on a motorcycle. So as far as people taking risks and you know, motor vehicle accidents, we actually have a high rate of death from accidents. So you know, the presence of brain death is abundant, but the acceptance for organ donation is not yet widely there. This is a questionnaire that I did for patients actually from Jordan, so a Middle Eastern country, not within the Gulf region, but this same concept applies to the rest of the region, and it's the same perception. This was a total of 456 participants, mostly in the age of 18 to 24. Those were actually mostly college students. So their educational level was mostly at a bachelor's degree level. When we asked these participants if they were willing to donate organs as living donor, they mostly said yes, which is the good news. Of course, when we ask them, when they say no, when we ask them why, 50% would either say, I don't want to, or I don't know why I don't want to. When we asked them if they would be willing to donate organs after death, also most of them said yes, which was also reassuring. Again, most of the participants who declined did not actually give a good reason for declining. And we gave them multiple choices, you know, religious, social, health, and they just didn't have enough information. When we asked the participants if they were willing to receive an organ should they need it to survive, they mostly said yes from a living donor, but they were almost split in half when it comes to receiving the organ from a cadaveric organ. So even receiving an organ, if they needed that from a cadaveric organ, was questionable for them. Here is the alarming finding for me. When we asked the participants if they were medically responsible for a family member and if they would be willing to donate an organ on behalf of that family member, most of them said no. So while people say that they're willing to donate their own organs, when they're in a position to make a decision on behalf of a family member, they're mostly going to say no because they don't want to take the responsibility for that decision. So as you know, in the Middle East, especially in the Gulf region, where the temperature could get to 130 degrees Fahrenheit or 50 plus degrees Celsius, people will have to be creative when it comes to solutions. So some of the solutions that we were trying to work on and we already established would be regional collaboration to create high volume programs sharing the wait list and management protocols, international collaboration with North American and European centers to provide what's missing locally. In many of the centers around the region, for example, there's no cardiac pathologist who can interpret cardiac biopsies. I've had a couple of solutions for this problem myself, as I had the experience establishing a couple of programs in two different locations to follow heart transplant patients. But this is easily, managed by collaborating with pathologists elsewhere. But importantly, international collaboration with new heart transplant centers outside of North America and Europe, simply because of the donor shortage in North America and Europe. Many of these programs are now becoming more reserved to accept international patients. So now we're exploring more transplant patients on the Asian side, and we have had successful collaboration with certain centers, for example, in India. Laws and regulations on brain death and cadaveric organ transplant are still a big hurdle for the establishment of heart transplant programs. However, in the United Arab Emirates, a year ago, the law was passed for cadaveric organ transplants, and actually the law for the definition of brain death was also passed probably 6 weeks ago, and the first cadaveric case was done. It was a kidney transplant that was taken from that donor, and the heart and liver were actually shared with Saudi Arabia, but we're on the way of starting our own heart transplant program locally. So similarly, in UAE, 2/3 of participants in a survey that was published to represent the country also said that they would be willing to donate organs if they're brain dead. Importantly, the responses might change if they were doing it on behalf of family members, as I mentioned. So in summary, most patients with heart failure need better heart failure care, not heart transplant. In the US, only 1% of all advanced heart failure patients get heart transplant. Regional heart transplant statistics are significantly below current needs. Heart transplant is the culmination of efforts put in by all members of the multidisciplinary team. It requires significant dedication and resources. Significant public awareness is needed to increase organ donation and encourage acceptance in our region and also around the world. Thank you very much.
Thank you very much for a very interesting paper. And because we are short of time, we have a time for one short question. Professor Hetzer, you open your, you would like to ask something? No? No. Okay, so thank you very much. And we move to the next paper. And this is the paper, Heart Failure Surgical Treatment, colleagues from Pakistan. Not here. Did they give you the presentation? Do you have? No, you don't have it, so probably they are not here. So we move to the country we are guests from. It's a heart transplantation program in Kazakhstan. Wake up him and come on.
Good morning, dear chairmen, guests and colleagues. I'm very happy to be here, and we wanted to share with you our experience about the heart transplantation in our country. So this is a very interesting situation that we are celebrating the 50 years anniversary for the heart transplantation, and we did just first transplantation in Kazakhstan just 5 years ago, and it is very big gap, 45 years gap. Why it was so? The first cardiac surgery was performed 1958 for the first case, and after that, since 2004, there are only 200 cases a year in 2 places, in Karaganda and Almaty city. Right now, it is different situation. We have 27 places where we can do the heart surgery. And we opened just 6 years ago, new center, when we started to develop the surgical treatment of heart failure program. At the same time, we, after just 1 year, we celebrating that 5-year anniversary, and here you see all of our transplants. They are celebrating 1 month ago, the first transplantation, the heart transplantation. Before we started our heart transplantation program, before the opening, we started to teach the team and team education, teach the surgeons, anesthesiologists, cardiologists, perfusiologists, and nurses also. At the same time, we did the beginning of the surgical treatment. We started with VAD implantation with Jan Pirk in November 2011, and we started with implantation of the system HeartMate 2 Torotec and the HVADs. And the same time we started with our help from Vilnius, from Lithuania, the program with another pumps, so a combination of the pumps. And we did with Professor Pirk on August, the first transplantation also. Many help was from the Walter Dembitsky and from Jan Gummert, and we started using the first organ care system transportation and the first lung organ care system transportation also. So it is our experience about, we have every year we have about 50 surgeries, and the first years was the one transplantation we started, and after that we have the decreasing number of the VADs and increasing number of transplantation. Right now we have 33 cases, and just the day before we did 2 more implantations of the HeartMate 3. That was a master class. And it is very difficult scheme, but you know every point of that scheme, that we are managing the heart failure treatment in our center. So we have that heart failure room, and we are coordinating the patients who will go to the VAD assessment or optimal medical therapy or electrophysiological treatment, other surgery, or directly to the heart transplantation. So it is the data from the ISHLT by gender, and it is a combination of donor and recipient numbers, and we see the pretty similar situation in Kazakhstan like in North America. Another interesting scheme from ISHLT, donor and the recipient age. We see here that the donor age are about 40, but the recipient age in the world, they are older than in Kazakhstan. Right now we have a situation like here, because we have very young population of the recipients. It is also about 40 years. Here we have the scheme about the diagnosis before. Similar situation that non-ischemic cardiomyopathy, it is the half, 49% in the world, and we have 50% here, but 35% in the world, they are ischemic. But in our country, it is about 17%. And we think that it is about the age of our recipients. We have a lot of experience at the moment about bridging the patients to the heart transplantation with assisted devices. And at this time, we have about 50% bridged patients in our country. The situation about the treated rejections in the world, that it is about 15 to 18 treated rejections, and we are not observing any rejection during the first year in our patients. But in the situation about the needed helps with renal dysfunction, the first year it is 22% worldwide, and we have unfortunately about 40% of the patient who needs any kidney help. It is survival year by year, and we have the same situation in our center. The results we think is good. And it is the very interesting case which are presented by Professor Pia. This patient was admitted in Intermax 1, and we decided to put him on the Centrimac for the left and right side, both of them. And the patient was fibrillated for 40 days, and he was awake, and he was on that system and was successfully transplanted after the operation. So it is only 3 weeks after the transplantation. Another case, very interesting case, it is 16 years old Marfan patient, and we discussed about him with a clinical specialist from the Thoratec and another companies, how to manage him. He was on Intermax 2, and we decided him put the HeartMate 2 with the Marfan syndrome. He was on that system 3 years, and he started to have the infection from the driveline, then goes to pocket, and we decided to explant the HeartMate 2, and we put him for the central ECMO, and he was on ECMO and successfully transplanted, and we thinking that the Marfan syndrome, it is not the contraindication for the VAT or transplantation. And the interesting point, he married to the patient who, at the same time, we did redo the 3-valve mechanic to biological, and they delivered the baby after 1 year. And what we are observing that we see that the stars, it is what we see, it is the past, and we hope that in the future we will go to another big points. So thank you very much.
Thank you very much, and congratulations to your nice program, and it's open for discussion.
I'd like to ask you a question. This is a very good program, as all your activities are very good. I have seen that most of your recipients are pretty young. You have any kind of rules as to age limit? And does this correspond with your donor organ availability?
Thank you very much, Professor Hedza. It's a very interesting question that we have a younger population of the recipients, and I think that in the future, when with developing of that cardiological and cardiac surgery in whole of the Kazakhstan, it is not problem with only one center, it is problem with the country, with the nationality, and that's why we have the patients, not only the patients for the transplantation, we have younger population of the patients doing routine cardiac surgery. So that's why I think that is the problem. We will go maybe after the 35, 50 years, the population may be older than like in Europe or the US. But at this time, we have that problem. Thank you.
Are you satisfied?
Also, I understand that you had a very low rejection rate. If I understood this correctly, during the first year, you had very low or no rejection at all.
Yes, that's why I showed you this scheme, because the first year we observing no rejections. I don't know, maybe it is a good cardiological treatment.
This, of course, is in contrast with the experience of most of the groups who have the largest number of rejections during the first year. Yeah?
Sure.
Do you have any explanation for that? Or we have a very good compatibility of your recipients and donors?
Maybe, maybe yes. Thank you.
Okay,
Well,
thank you.
Good protocol. They have just simply good protocol.
Jan, I have
Yeah.
very short question, Eric, about the last cases with patients with the Marfan syndrome. It's very seldom indication for a heart transplantation, Marfan syndrome. It was really a final stage of heart insufficiency.
You mean aortic valve?
Yes.
So
Marfan
the-
syndrome, yeah, is very seldom. If you see some statistic, it's very, very seldom. Yeah, but you perform heart transplantation.
Yes.
Yes, it was a really final stage of heart insufficiency in this patient.
Yes, so
Before.
he was in Intermax 2 and needed 2 inotropes in the ICU. He was 16 at the same time. We decided that it was a big collaboration, and this was big discussion with, through emails, and we sent the data, if I remember, to Professor Pirk with this situation. And
Maybe it was coincidence of two diseases, no? Marfan syndrome was not the indication for heart transplant. Maybe there was some cardiomyopathy, or it was aortic insufficiency.
there was no aortic insufficiency.
So probably there was a coincidence of two diseases. Otherwise, Marfan syndrome should not be.
Because I think it was not a, exactly Marfan syndrome. It's a maybe combined Marfan
that's what I
syndrome
mean.
and really cardiomyopathy. Really, yeah, maybe. Because
think
the
so,
Marfan
yes.
syndrome, it's not depend from a size of the heart. You perform typical surgery and the heart.
The question was that this patient was the implantation of the assisted device and how it improved the circulation, and how the outflow graft will goes to the aorta, and a lot of questions we had at that time.
Like a second stage.
I think Marfan patients are well distributed among the transplant programs all over the world. I remember the time when it was a discussion whether you could transplant Marfan patients at all, because there were some questions about stability of the anastomosis and things like this. But this has all been overcome. And of course, there are whole families with patients, with Marfan patients who have cardiomyopathies. And also the question of assist device, I fully agree that, of course, it can be handled very well if you take the real measures in the terms of placing the anastomosis of the grafts and so on.
Okay, so
Thank you.
no questions from the floor? So thank you very much. And we move to another paper for perioperative period in heart transplantation and so on. Colleagues from Moscow. They are not here? Do you have their presentation? Did they give you? No? So then we move very quickly to another paper from Italy, Bridge to Transplantation in Patients with Cardiogenic Shock. Are the colleagues from Italy here? Did they give you the... No, they didn't give you the presentation. So then, hopefully the colleagues from Pakistan are here. Are there stem cell therapy available for damaged heart in heart failure? You have the presentation from the colleagues from Pakistan? Not? You give them some, you have to tell them something, you know. You have to beat them. Then we move to another paper, ex vivo allograft perfusion and condition for heart transplantation, single center. And that's you, you are here. Finally, good.
Good morning, dear moderators. Good morning, our college. The topic of my research is ex vivo allograft perfusion and monitoring for heart transplantation, single center, 1 year follow-up. Regards to heart transplantation, Hassanein et al. Have developed the OCS, and there had been 4 global and multicentral clinical trials using the OCS, as shown in table, and the device has been used in 7 countries and currently utilized in 16 centers, encompassing more than 250 human heart transplants till 2016. And in Kazakhstan experience, from 2014 till to 2016, we have 31 human heart transplantation with the OCS. In 2012, we initiated the first heart transplant program in Kazakhstan, and donor hearts are often transported from distant regions, more than 1,000 kilometers, to be transplanted at our center in the city of Astana. And to date we have 56 patients transplanted in 5 years, and of them 44 patients with the organ care system. There are currently 2 methods for ex vivo preservation of donor hearts. It's the cold storage and a system for ex vivo heart perfusion. The latter method eliminates the risk of time-dependent ischemic injury to the donor heart during cold storage. And the organ care system is a portable organ perfusion and monitoring system that's designed to preserve donor hearts in a physiological functioning state ex vivo for transplantation. In this context, the standard approach for heart preservation is to use a cardioplegic solution such as custodiol in hypothermic condition. And the duration of the cold ischemic time when using custodiol is more than 3 hours, and the solution is perfused under hypothermic condition. And we modified standard method of donor heart preservation using blood cardioplegia and conditioning ultrafiltration with the levosimendan during transport from the donor hospital to our center. Blood cardioplegia is an alternative method for heart preservation, which would provide perfused at normothermic and physiological conditions. We hypothesized that blood cardioplegia could provide perfusion the better outcomes of patients and may result in better postoperative outcomes in this patient. And to our knowledge, blood cardioplegia and conditioning has not been previously studied in the OCS. Conditioning consists from ultrafiltration and levosimendan. Ultrafiltration during perfusion reduces the circulating inflammatory factors, reduce the endotoxins, increase the hematocrit. And levosimendan, we have some evidence that levosimendan have cardioprotective effects, and levosimendan is used to heart failure. In this study, we performed a retrospective analysis of prospective collected data at our center, and between May 2014 to July 2016, 31 patients with the heart failure underwent heart transplantation at our center, and we use the OCS for heart preservation in all cases. Of this, we arrest the donor heart before explant and before implant using blood cardioplegia and conditioning in 19 cases. And in 12 patients, we used standard custodial solution. Recipients were assigned to blood cardioplegia or custodial in alternating fashion based on their order in the recipient waiting list. Perfusion and cardiac function parameters were continuously monitored, and the main outcomes of interest were 1 year survival, freedom from any treated ejection, non-fatal myocardial events, perioperative parameters, sinus rhythm restoration time, and post-operative parameters. Results. In the donor group, the mean age was slightly higher in the custodial group compared to the blood cardioplegia group. Other prognostic risk factors at baseline were similar between 2 groups, including gender, body mass index, CVA, and left ventricle ejection fraction. In the recipient group, the mean age was slightly higher in the custodial group compared to the blood cardioplegia group. And other risk factors at baseline were similar between two groups, including gender, body mass index, diagnosis, and implanted VAD. Results. Patients' survival and freedom from adverse events at 1 year after heart transplantation. Survival was in blood cardioplegia group 84.2% versus 83.3%. Statistically no significant. Freedom from rejection, statistical no significant, and freedom from non-fatal cardiac ejection is non-significant. Ischemic time and perfusion time was of donor hearts in the OCS have not statistically significant difference between groups. Only in blood cardioplegia group, perfusion in OCS slightly higher. In main chains in perfusion measure in OCS in the heart, OCS heart, they have no statistically significant difference between groups. And mean chains in lactate trends. The starting concentration in blood cardioplegia group was 2.7 and in custodial 3.2, and the ending concentration was 4.1 and 8.8, statistically significant difference between groups. And in tissue myocardial Doppler, we haven't statistically significant difference, and in all patients we have normal TDI, except for one patient in custodial group who have developed right ventricular dysfunction. The time of sinus rhythm restoration, ICU and ECMO duration was statistically significant. It is the time of sinus rhythm restoration in OCS, time of sinus rhythm restoration in recipients, and the mean length of stay in ICU. Statistically significant, higher in the standard custodial group. And the ECMO duration is not statistically significant. We have some limitation. It is the patient randomization, lack of donors, needed multi-central trials, more data to analysis. And in conclusion, the novel method for ex vivo preservation of donor heart using the organ care system provide less cold ischemia reperfusion injury of the heart, management of heart metabolism. Methods should be used in future to collect and analyze more data. Thank you.
Thank you very much for an interesting paper, and it's open for discussion.
Maybe a short question. Tell me please, how often did you use levosimendan after heart transplantation, and what is the main reason?
After heart transplantation?
Yes. What is the main reason?
Levosimendan,
right ventricle failure or other reason? What is the reason?
We use levosimendan in the OCS during transplantation. Not after transplantation.
During transplantation?
During transplantation in the OCS, it's in the primary solution.
And at that time you think about the possibility of right ventricle failure, like a protect it?
Yes, like a protection. Because we have some evidence that it is cardioprotective effects. And we use the patients with the more than lactate with the more than 5 because it's maybe limitation because Hamed et al. Defined a cutoff value of ending lactate 4.9 millimoles per liter and the most powerful predictor of graft failure after heart transplantation. But we use the in this slide we see we use the more than ending concentration of lactate more than 5 because we have shortage of donor organ.
Long distance.
So you are not using it routinely, only if you have on the pump lactate more than 5?
Lactate we do at the donor first, and in the starting of OCS perfusion, in the every 20 minutes, and in the end of perfusion. But very important, it is the starting and ending concentration of lactate level.
Thank you.
Venous lactate level. Thank you.
No more question? Or the chief would like to add something? No? Okay, thank you very much once more. And we will go to the next paper, the complex monitoring for diagnostic heart rejection after transplantation.
Good morning, dear colleagues. Let me introduce our modest experience of the complex monitoring for heart rejection after transplantation. I have no conflict of interest. According to the ISLG guidelines for the care of heart transplant recipients, 2010, for heart rejection surveillance, endomyocardial biopsy is recommended as class 2A. Non-invasive methods, echo, MRI, and laboratory markers have only class 3 recommendation. However, endomyocardial biopsy is quite an aggressive method of rejection surveillance. If we will strictly adhere to this protocol, then for the first year after transplantation, we must do 14 biopsies and accordingly receive 70 biopsies. Patients will be biopsied 25 times over the course of 5 years following heart transplantation. Also, due to sampling error with biopsies associated with the inhomogeneous nature of aqueous rejection, histologic false negative aqueous rejection can reach 20%. Besides being stressful for the patient, this procedure has a lot of serious complications, including death. The usefulness of surveillance biopsy in all patients 1 year after transplant is subject to debate. Since the guidelines of 2010, 7 years have passed. During this time, echo machines were significantly improved. New software was developed, especially tissue Doppler, imaging, PVTDI, and strain. Today we have gained the experience of using these techniques in early diagnosis of rejection. Interesting data was published in Europe Heart Journal Cardiovascular Imaging in 2015. You can see sensitivity and specificity indexes of different echo techniques in this table. PVTDI has very good indexes, sensitivity about 80%, specificity about 90%. Another permission alternative in the strain echo, but now these techniques are still not standardized. For diagnosis of vasculopathy, stress echo with dobutamine can be used. Vasculopathy is the complication which develops in 20% of patients during the first year after heart transplantation, and in up 75% within 5 years. Early diagnosis of vasculopathy is quite difficult, and so coronary angiography and IVUS are recommended. These methods have good sensitivity and specificity, low complication rates. And again, up to the present moment, they are not standardized. So, summarizing background, cardiac allograft vasculopathy, heart rejection, can arise and progress without symptoms. Routine invasive screening carries a risk of complications. Non-invasive diagnostic tests have not been accepted as the standard of care. Laboratory markers associated with rejection have low sensitivity and specificity. It is necessary to evaluate use of non-invasive methods of assessment of the graft in early diagnosis of allograft rejection, develop a non-invasive screening program for allograft rejection. We have analyzed the dates of 48 patients, mean age 41 years, males 81%, female 19%, follow-up period 21 months, 5 patients had positive HLA-1 cross-match from 3 to 10%, and 1 46%. And 4 patients HLA-2 from 2 to 12%. We have determined biochemical markers, CRP and proBNP level for all patients. In 41 patients, PV-TDI was performed. Coronary angiography, according to the guidelines, was performed 1 year after transplantation in aging patients who didn't have kidney contraindications. ILUS was made only in 5 patients since we have started to use this method in our practice a short time ago. We have performed the endomyocardial biopsy in 33 patients with a total of 64 procedures. We routinely use our immunosuppression protocol. First step, combination of ATG, tacrolimus, and solomidrol before operation. Then, until extubation, ATG plus solomidrol. After extubation, usually 2 to 3 days after heart transplantation, we start the combination of tacrolimus, Cellcept, and prednisolone. Biopsies results. In 80 biopsies, no signs of rejection, 0 state. In 44 biopsies, 1 air stage signs were found. And in 2 biopsies, 2 air stage signs. We had no patient with stage 3 rejection. In recipients with biopsy 0 stage CRP and proBNP levels were lower, and PV-TDI velocities were higher than in patients with any signs of rejection. But these differences were not statistically significant. Elevated CRP in patients without signs of infection and elevated proBNP increase the index of suspicion for rejection. However, CRP and proBNP elevations were not observed in every instance. Local velocities as a measure of systolic function in the majority of patients with rejection clinical signs were lower. However, in recipients with vasculopathy, PV-TDI velocities were not decreased in every instance. Perhaps indices of myocardium diastolic relaxation, specifically in relation to common and local early diastolic feelings, may be more informative. In this case, we can evaluate the diagnostic possibilities of each techniques for acute rejection. The patient, 31 years old, with dilatation cardiomyopathy, 2 years of mechanical circulatory support, heart transplantation in July in this year. Patient developed generalized fatigue and refractory lower extremity edema despite ongoing renal replacement therapy on postoperative day 30. Low ventricular ejection fraction was normal. Coronarography was not performed due to renal failure. 32 days after heart transplantation, biopsy was performed and acute rejection was diagnosed. ProBNP level was elevated at the time of clinical deterioration, then decreased significantly after pulse steroid treatment. CVP level was elevated. PV-TDI local diastolic velocity interventricular septum was lower than patient's baseline. Both of them have normalized after therapy pulse corticosteroid. The estimate of the local velocity of the heart wall by tissue Doppler imaging is a new useful tool for evaluation of rejection. In our clinical case, normalization in local diastolic function was observed after therapy of heart rejection. The local velocity of early diastolic feeling before therapy was 5.2. It is obvious how this local velocity increased after steroid therapy. It became 9.4. The deceleration time of early diastolic feeling has also improved. Patient had acute humoral rejection grade AMRI 2 as evident positive staining for complement C3D, C1q, and immunoglobulin A and G in capillary endotheliocytes, stromal lymphocytic infiltration of the right ventricle, and interventricular septum. Coronary angiography was performed in aging recipients 1 and more years after transplantation. One patient had the atherosclerotic change of the coronary arteries, older donor. One patient had diffuse concentric lesions of distal vessels. In 4 cases, minimal stenosis were found. Cardiocolograph vasculopathy generally refers to concentric liminal narrowing of the epicardial and intramural coronary arteries. Coronary angiography has a high specificity of 100%, but only moderate sensitivity of 80% in vasculopathy detection. The intimal changes in vasculopathy are best detected by intravascular ultrasound, which has become the gold standard for the early diagnosis of vasculopathy. The diagnostic value of IVUS has significant clinical utility in routine screening of heart transplant recipients. 3D IVUS with simultaneous assessment of virtual histology may add important information in the clinical evolution of heart transplant recipients. And the second patient, 25 years old, postpartum cardiomyopathy, transplanted 2 years ago. She was admitted for routine surveillance. During clinical examination, we found a high proBNP level, echo low left ventricular ejection fraction, coronary angiography, diffuse concentric lesions of distal vessels, biopsy signs of cellular and humoral rejection. In the 3 months after heart transplantation, local diastolic function was normal, but during rejection, the peak velocity of early diastolic filling decreased from 16 to 6.5, consistent with impaired diastolic function. In this case, we use the speckle tracking, which reveals the reduction of strain from a normal value of minus 22 to a markedly abnormal of minus 10. It also suggests that this new ultrasound tool can be useful for early recognition of both heart rejection and vasculopathy. Cardiocolograph vasculopathy is currently the limiting factor in long-term allograft survival. Vasculopathy is presented on this coronarography as diffuse concentric luminal narrowing of the circumflex artery. Patient had cellular and humoral rejection as evident by positive staining for complement C3D, C1q, and immunoglobulin G in capillary endothelium, stromal lymphocytic infiltration, cardiomyocyte degeneration, focal fibrosis, interstitial tissue edema, and endothelial proliferation. From 48 recipients included in this study, 8 patients died. 6 of them had different reasons for death, although the majority of them had biopsy results 1R stage. 2 patients with great probability had humoral rejection. 1 recipient had high CRP and proBNP levels, low left ventricular ejection fraction. However, histology shows 1R stage of cellular rejection. PVTDI velocities were also decreased. The second patient initially had high levels of HLA-1 antibody. In conclusion, non-invasive methods of assessment of the graft can assist in early diagnosis of allograft rejection. PVTDI can be used as an indicator of endomyocardial biopsy. The results of our limited experience warrant additional research of non-invasive methods of early detection of allograft rejection and vasculopathy. Thank you.
Thank you very much for interesting paper, and we have enough time for discussion. So, with your good results with the non-invasive diagnostic, do you plan to decrease the number of biopsies?
Yes, I think we must, firstly, we must do biopsy first 6 months after the heart transplantation. And after 6 months, maybe a patient who have low risk rejection, biopsy maybe do only indications. but patient who has very high risk rejection must be only protocol, according ISLHT guidelines.
Have you thought of any electrophysiological monitoring concepts?
Yes. After heart transplantation,
yes.
All patients have diastolic dysfunction. And maybe a new approach of echo monitoring of this condition need standardized, and more research investigate need. And these parameters vary depend condition of patient. For example, heart rate, arterial hypertension, and age.
Okay, as you know, we have been using a telemetric electrophysiological monitoring at long distance for many years in more than 1,000 patients. And in most of the patients, in particular in children, there was no need of a biopsy at all. So how would you monitor, for instance, transplanted children? You have children that are transplanted? How do you monitor the rejection in those? Because biopsy is usually difficult in smaller children.
Yes, I agree. We have 5 children after heart transplantation, but this transplantation heart made in India, and we following up this patient in our clinic, in our center, and biopsy not made in these cases because it's more agree for more injury for children. I hope in our future work, our future investigation, we used LOMAP, genetic markers of rejection, and telemetric vision for this patient.
One more.
Roland, a very interesting remark to your question. I have shown today the unique telegram from Shamway to Christian Bernard.
Yes.
And he told, Chris, try to see AKG. It's very important for a diagnostic of rejection.
Yes, of course.
50 years ago.
No, I know, because the Stanford group, they had made studies in animals already before the first human heart transplantation by, let's say, adding the voltage of the R wave in 5 leads to a summary voltage. And there's a paper by Richard Lauer from the 1960s where he has shown that this is very indicative of rejection. And this is why we have been following this telemetric monitoring of patients by day voltage measurement. For instance, I had a patient from Hokkaido in Japan, whom we transplanted in Berlin. He went back to Hokkaido, and he was monitored every day for about 1.5 years. Or we had a patient, I transplanted a patient from Bratislava already in 1987, and she was monitored for 2 years with this system. And there was no, we never missed a rejection in those. But anyway, that's another topic. I want to ask you another question. You showed a case with very advanced peripheral transplant vasculopathy, yeah, with very thin coronary arteries. When do you decide to think about retransplantation in such a patient?
Unfortunately, one case, this case I demonstrated, she died. It was months ago.
Yes.
And it first our cases with vasculopathy. And I think in future we maybe will be done this more often coronary angiography for patients with high risk development vasculopathy, and then maybe retransplant heart.
Thank you.
Mahabat, it's not a question but a very short comment. I remember very well about our job together in Moscow, and it was very interesting for me to hear your report in the field of heart transplantation and about the rejection. I congratulate you. And I would like to see that as longer became distance from a heart transplantation, as lower became the risk of rejection. And the main problem became oncology disease. We have 30 years experience. Oncology disease became more and more in the long distance after transplantation. And no rejection. Rejection is within first 1 year. It's like a
Yes,
comment,
thank you for
not a question.
these commentaries. Thank you.
Thank you for your report.
Thank you.
No question? If not, thank you very much once more. And we received some information. I don't know if we have to tell the people about changing in the program. That here in the room 1, the plenary session, Dr. Fraser is absent. His paper was cancelled. Then there in other rooms. Maybe it will be available for everybody, so I don't want to disturb you with this. It's only some papers were cancelled, and moderator in the room 6 in the congenital heart disease is absent. Okay, so thank you very much, and we can close the session. We are very much ahead of time, so you will have a long time for coffee discussion. Thank you very much.